you.
So, just make sure everybody signs in, and I'm gonna give the rest to David, alright? Thanks for coming in, man.
You got it. Good morning,
Thanks for
everybody.
breakfast, too.
Yeah, absolutely.
Yes, thank you.
Feel free to grab any more, and we got 3 things of coffee, so you guys will at least be awake for the rest of the day. But I don't put you to sleep right now. So, again, David Wolf with Medtronic. I've met a lot of you. For the people I haven't, nice to meet you. I do cover quite a bit, so PillCam, high resolution manometry, Bravo pH testing, Barracks Halo RFA, Beacon EUS. So I touch a lot of different parts of this department. So if you guys ever need me, Mitch, Alatris, Shanetta will have my contact, Judy has my contact. So please let me know if anything's going on with the equipment, with any of our platforms. I'm here to help, I'm local, so I can be here in about 10 minutes. So happy to help you guys, making sure you guys feel supported. And breakfast is a good way to do that, making sure you guys know that we appreciate all the things you guys do for us on a daily basis. We can't stay in business without you guys, so I appreciate that. And I know GI Nurses Week was a couple weeks ago, but this is kind of your GI Nurses Week from Medtronic. We were a little busy the last couple weeks, so with you guys and scheduling and everything, so this is kind of us celebrating you guys this morning, of course on a super gloomy day, and hopefully we don't all burn down. It sounds like
Burn it? I don't want to burn.
it sounds like there's supposed to be a horrible storm, but I've never been anywhere in the country that amps up weather more than St. Louis, Missouri. So
Sounds like Texas got it bad.
yeah, outside of Dallas got hit really hard. I have some friends that were sending me pictures of tornadoes and stuff.
Texas should have everything bigger.
That's your.
All right.
Sorry, you're like, I want my good time.
Sorry.
You're good, no worries, no worries. We're still waking up, we're getting coffee, we're good. So today what we're gonna talk about Barracks. It also is called Halo. It's been called 3 different names since we've acquired it. Covidien actually bought it, and then Medtronic bought Covidien. So it's been through the ringer, but even talking with Mitch on the way in here, it is the tried and true system. This thing is bulletproof, knock on wood. It does a really good job of what it does, and from a high level overview, I'm sure most of you guys have heard about this, being in the endoscopy space, but very high level overview of what we're doing with the system. So we're treating low grade and high grade dysplastic Barrett's esophagus. So what it is in a nutshell, precancerous tissue that happens to be and progress from GERD coming up. So their acid reflux and stuff like that will start to change the esophageal mucosal to precancerous, and then will eventually transition to cancer, esophageal cancer. So when we came out with this system, we of course have to develop a study. It was called the SURF trial. It was so effective that they actually canceled the trial early and brought it to market early because of how effective it is of treating that precancerous tissue. So of course that these patients aren't transitioning to esophageal cancer. So that's basically from a high level overview. One thing to always keep in mind with this system, this is not a one and done treatment. This treatment takes anywhere from, depending on how long the segment is, it can take anywhere from 5 to about 8 treatments, and this is with a compliant patient. The patient is non-compliant, does 0 lifestyle changes, still drinks and smokes, and eats whatever the heck he or she wants. It's likely that those PPIs, either they're not taking them or they're not effective because they're not making any lifestyle changes, so that GERD will continue to come up and that esophageal mucosa will continue to change and progress to esophageal cancer. So I always say, like, sometimes we can eradicate a short segment Barrett's esophagus, low grade dysplastic tissue with a couple treatments. I've seen 8 centimeter segments that take 12 treatments to do, and that's even with a compliant patient. So just keep that in mind, that especially when we're educating patients, that this is not a one and done treatment. This is something that we're getting you to be a part of a program. You're part of our Barrett's RFA program, or Halo program. Just so they know that, all right, I'm coming in, getting treated, and then I'm done, and I never have to come back and do this procedure again. These patients do sometimes complain of pain. Chest pain is really the biggest one that we find. And it's all right. that's what they'll complain of most. So we just want to make sure that we have to make sure that and educate these patients that they have to come back for these subsequent treatments, or else it will continue to progress at different rates depending on how compliant that patient is, like I said. So that's what Barracks does in a nutshell. Again, it's been out for 10 plus years. There's really not been a ton of innovation with the system besides some additional catheter improvements that we've made, and I'll go over those in a little bit. But it is truly a bulletproof system. I think Dr. Hotcham is doing it. Are there any other physicians that are doing it?
Yeah, Cheeseman, Bundy,
Okay.
Taylor.
So pretty much everybody. That's good. Okay. So if anybody's worked with Dr. Hotcham in one of these cases, she's very particular on how she likes it. So I'll kind of walk through some of what her expectations will be in the room, just because I know how she works in the room. Not super familiar with some of those other physicians with RFA specifically, but I'll kind of walk through some of what her expectations will be of you in the room. But we'll talk about the system as a whole. So we got a power cord just like every other system. It's plugged in the back here. We have a foot switch that ablates and then auto inflates and deflates our 360 Express balloon. That will be placed, of course, by the physician's foot, since it's a foot switch. On the front of the screen, you'll see a bunch of different segments here on the generator. You will never, ever, ever have to adjust any of these settings. All of these settings are preset to whatever catheter that you guys attach to the system. They will automatically populate. Please, please do not touch any of these buttons up here. It can, what we've seen happen is we change the wattage of they have the ability to change the wattage of the catheters. We do not want to do that. That changes the effectiveness of either down. Of course, it changes the effectiveness in a negative way. If you turn it up, it might overablate. We don't want to overablate as well. So please, 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 we dialed this in. We don't need to do any sort of settings on the top here. And then we have our high efficiency cable here. So this cable, which it was great to see that when we pulled this card out, this cable was detached from the front of the system. We don't want to roll this thing around with this cord attached. As you guys can see, it sticks out about 6 to 8 inches, right? So when we're wheeling this thing in and out of rooms and this thing gets caught, this is like a $5,000 to $7,000 cord. So we don't want to have in any way have this be a nuisance necessarily, and when we're rolling in and out of rooms, we don't want to have this as an obstacle to break this. So again, when we're done when we bring it into the room, we want to make sure we connect it. But at the end of the case, at the end of the procedure, please undo it, wipe it down, and then either place it on top, or there's also a little drawer here if it's not super full. It is super full, so place it on top here. From a procedural standpoint, what's really great, if we forget everything and the coffee hasn't kicked in yet today, we have Barracks 360, so that is this catheter here. And we have Barracks focal catheters, which are the TTS, which is this one. And we have the assortment of other focals as well. So they're all considered, the through the scope and the focal catheters are all considered focals. And then we have our 360 Express, which is our circumferential auto-inflating and auto-deflating balloon. So those sheets are in here, in the drawer. I'll also send them again to Mitch, so if we run out of them, we can reprint them off. But truly, truly, this walks through absolutely everything that we would need to know for the procedure, depending on which catheter. Make sure we're using the correct sheet for the catheter that we're using, right? So it changes a little bit. There's a little bit more work and involvement with the 360 Express than there is for the focal catheters. So just make sure that we're following and we're utilizing the correct quick reference guides for the particular catheter that we're going to use for the case. The catheter difference will determine, once they go down, they'll do their EGD and will determine pretty much they're either referral or they're the specific physician's patient. They'll already typically know how long the segment is. but depending on how many treatments they've already had, we'll go down and we'll evaluate. How they're going to evaluate is they'll give you, it's called the PROG classification. So they'll tell you how long the segment is. So they'll measure how much circumferential Barrett's esophagus we have, and then they'll measure how long that top of the intestinal metaplasia goes up into. So that will tell you how long the segment is. So that will determine which catheter we use. For a very, very long segment, Barrett's esophagus, anything basically over 3 centimeters, it's highly recommended to use the 360 Express. This is a 4 centimeter electrode, so you're getting that entire area, and you're also getting a full circumferential burn in one burn. With these focal catheters, you can imagine if you're using this little or smaller TTS through the scope catheter, it's going to take you quite a long time to burn in anything over a 3 centimeter segment, because you're burning, and you're doing the same motion in a circumferential fashion. So just be cognizant of that going in, we might not know which catheter we're going to use, and that will just be determined when we go down and do our index EGG. Something that a couple of my accounts, again, I did quite a few of these in-services for pretty much every single one of my accounts, and some physicians started to get away from using Mucomist. Mucomist is a solution that we make as a staff, and we provide to the physician before we go down and ablate with any catheter. It doesn't matter which one we're using, but any catheter. What that does is that creates a very clean mucosal when we go down and burn. We don't want anything in the way in between that catheter and the mucosal wall, right? Whether that's anything at this point, right? So it could be any weird fluids, it could be tissue, it could be, hopefully not, but maybe food in some way, remnants of food. We just do not want anything in between that catheter. Let's see if I can get this out. That catheter and that mucosal wall. We want as clean of an area as possible. What ended up happening was some physicians got away from thinking that it was effective or not. Per our IFU, we need to use Mucomist. That makes sure that we are providing 100% efficacy of our system. So please, if we're not doing that now, and we don't have to say if we are or we're not, but please continue to use that. It is a 1% dilution of Mucomist, and again, all of these quick reference guides, it will tell you that as well. So you'll see right here, the 1% mixed in plain water. Do not use saline. That's very important. So if we have gotten away from that, please let's get back into that process. Let's make sure that that's ordered prior to going into the procedure. So again, very high level, patient will come in, we'll know how many previous procedures that this patient has had. If it's a first, it's likely. If it's a longer first treatment, that's what we're going to assume now with this patient. First treatment, we're likely even probably going to use the 360 just because it is a circumferential burn and it gets a really, really clean burn of that entire area, and also cuts down on procedure time, even with some of the additional steps that the 360 Express does. So we roll the patient in, we'll have the cart over here. The cord will be nicely placed on top because we talked about that. Again, if you guys see this, even in storage with the cord on, please take it off. We just don't want this cord to break. Again, it's like $5,000 for this thing to get replaced. So if we can just be cognizant of that, that will help everybody in the long run. This cord here has a white dot on top. The white dot aligns with the top of the cord here. It's not super easy, but what we end up doing is make sure that dot is on top, and then we'll slowly start to screw the collar. So it has a little rotating collar here, and we just want it hand tight. Nothing of our equipment, none of Medtronic, Covidien, anything requires excessive force. Really, no medical device requires excessive force. So please don't use excessive force because that might cause the cord to break. Once this is hand tight, kind of jiggle the cord a little bit because that might give you a little bit more thread that you need to screw on here. So just make sure that it's not loose in any way, but it's not over tightened. The other piece that we typically forget is we need to connect this cord. What this cord is, this is super important for the 360 Express. Let's just get in the habit of plugging in every single time. It doesn't matter if we're using the focal or not. This thing is not plugged in and we go to use the 360 Express. Well, if this isn't plugged in, it won't inflate. And then we'll get an error on the system and it will cause some headaches and we'll start to go through our troubleshooting. But if we just get in the habit for every single case, please plug this in and it just clicks on. What you can do is just lightly pull back on it just to make sure that it's secure on there. Once we are all connected, we've done our index EGD, we have now determined, the physician will say, we're going to move forward. It is a 4 centimeter segment, all circumferential. So that's when we're going to use our 360 Express. It's a perfect instance to use this. So they're going to recommend, or they're going to say, hey, let's grab our 360 Express. They're right on the side, on the right side here. For the 360 Express, it is a little bit more involved than the focals. There's extra steps. We have to place the catheter over a guide wire, place the catheter, burn. We have to take the whole system back out. They will go down, they will use a cleaning cap specifically for the 360. They'll put this little cap, what it looks like is like a little plastic shovel that goes on the end of the scope. They'll go down and they will scrape all of that mucosal off. It's white, coagulum, it'll look like it's typically pretty sticky. They will wipe all that off and then we restart this process. So what the process is, we'll make sure that we have a guide wire. Our guide wires are not unique to our system. So if we run into something else, and you can grab a very similar guide wire and it will work just fine. So there's nothing unique about our guide wire with our system. So you'll grab a guide wire, you'll grab a 360 Express, and you will grab a cleaning cap. So once we go down, what we'll do is we'll place the guide wire. As they're pulling out the scope, be aware that they're going to require you to grab the guide wire at the tip of the mouth. We want to make sure that that guide wire stays in, so when we're retracting the scope, that it does stay in the patient. If we do not grab it as that scope leaves the mouth, that guide wire will come with the scope and will pull out completely. So be aware that will be asked of you. You will hold it by their mouth and they will loop it into your hand typically, and then you will hold the guide wire in place. Once the guide wire is in place, we will open up the catheter. The catheter, it's probably really hard to see, but there's a little hole at the end of the catheter here. That's what you're going to place the guide wire into. If you have really shaky hands like I do, it's not super easy to place it in there, but you'll place the guide wire through here. There's a little segment on the top here that will come out the other side. Just be aware that, like every other guide wire, it will fly everywhere if we're not under control of it, so just make sure that we're cognizant that it goes in the front here, comes out the back. Sometimes we forget that the guide wire does come out the back here, and it starts to fly around the room and we have to get it under control. So just like every other guide wire, it's a wire and it will start to go everywhere if we're not under control of it. So we will EGD, we will have made our mucomist dilution. They will spray the dilution. We will place the guide wire. We place the catheter over the guide wire. And then once the catheter is fully in place and we have it at the correct measurement from the measurements that they gave you previously, once we're in place, then we connect it to the system. We do not want this thing connected to the system until we are fully in place. That's difficult sometimes because that becomes a part of our process, getting everything connected, then dropping it. The thing with the 360 Express especially is if we click auto inflate on accident, it will auto inflate whether we're in the position or not. Not super detrimental in any regard if we're anywhere below the UES. If we're like right by the UES and we start to inflate, that thing's gonna potentially cause harm to the patient. So we wanna make sure that it's down, it's in place, it's by our markings, and then we connect it to the system. Once we connect it to the system, this one is my demo handle, but it's going to give us some errors, but what it'll do, it's a little dot, again a collar here, it clicks on, it's not going to give you that error because this says what the heck is this catheter, this is not a right catheter, why did you connect this? But what'll happen is once we connect the catheter, all of these preset settings that we talked about will pre-populate. Again, please do not touch any of these. They are pre-populated per catheter. There's going to be a plastic filter that's going to be on this handle here. we want to make sure that this, again, it's a lot of collars with this turning collars on this system. So there's going to be a plastic filter. Please use your imagination because mine fell off. But what you'll do is you'll connect this cord here to the filter here. This connection here is typically where we're going to find an air leak most of the time. So if we go to auto inflate, we click the auto inflate button and it says air leak in your status window here. This is typically where the air leak is happening, is this cord here is not fully tightened down to the filter, and or the plastic filter isn't twisted all the way down either. So it's one of the two. Either the plastic filter is not twisted down, this piece is not connected and or tightened, or we didn't listen to David and we didn't connect this piece. So it's 3 separate things. So it'll be filter, connection to the filter, or connection to this system. Once we've done that, if we had an air leak error, that's pretty much the only error that you're going to have with this catheter and or system in general. Sometimes we'll get a defective catheter. For a defective catheter, you're going to see this. It's not going to recognize the catheter. What we'll do, go back to the air leak. So if we've checked all the different positions here, we've connected this, and I'd say 98% of the time that works. If for whatever reason, if this connection is tight, this connection is tight, and the air filter is tight, that's typically a faulty balloon in the catheter. Again, this happens very, very rarely, but I want you guys to feel comfortable with it if we do run into it. If these connections are all good, let's grab this catheter, disconnect it, and we have to pull it again out of the patient. It is an additional time and the physician will likely be frustrated, but I will promise you that this balloon will not inflate if we've done all of our connections, we've done all of our troubleshooting, and it's still not inflating. It's not going to inflate by doing anything else. So we do have, just like every other medical device, we do sometimes have faulty catheters, unfortunately. If the 360 Express is not inflating, and we've done all our connections, please disconnect, please remove it from the patient, and set this catheter aside. None of our equipment, if anything is faulty, please set it aside. Please get it to Shanetta, Mitch, Elatris. We replace these. We call them into tech support and we replace it to the hospital because it didn't work as it should. If we throw these away, there's no way to replace it. We do require that we get these back to give you guys the full reimbursement for it. So Bravo, Barracks, PillCam, Beacon EUS, if there's any fault in any of the systems due to the actual equipment itself, not physician or user error, then please set it aside and please get it to administration so we can get it replaced for you. Back to the 360 Express. If we connect it, we've done all of our connections, and it's not recognizing the catheter whatsoever, let's turn off the system, give it about 30 seconds, turn the system back on, reconnect the catheter. If it's still not recognizing, it's not going to recognize it. Again, it's likely a faulty catheter. Let's pull this out of the patient, let's open a new one, and let's proceed with the procedure. The more time that we spend trying to sit and look at the front of the screen, it doesn't do anything. I've tried it really hard. I've thought it into existence that this would work, and it just doesn't work. So if it's not recognizing it, please shut down the system, turn it back on, reconnect the catheter. If it's still not recognizing it, it's a bad catheter. Let's proceed and move on to opening a new system, and we'll place this aside in a BioKit bag or whatever you guys do and get it to administration so we can get it replaced for you. So we are down on the patient, everything is fine and dandy. We have no air leak, we have all of our preset settings, it's recognizing the catheter, the foot switch is by the physician's foot. We are in place. Where we want to be is with the 360 Express is 1 centimeter above the intestinal metaplasia. So we'll start 1 centimeter above the Barrett's esophagus. We will burn. We will then, depending how long the segment is, but we're assuming it's a 3 centimeter segment. We'll start 1 centimeter above, which is perfect length for this because it's 4 centimeters. So we have 1 centimeter above the intestinal metaplasia, and then there will be 3 centimeters below it. So with a 3 centimeter segment, we can knock that thing out with one go in with this. If it's anything longer than that, we will burn, we will push the catheter in distally, and we will burn one more time. So we will cover that entire Barrett's esophagus, 1 burn, 2 burn, depending how long the segment is. We will pull the entire system out, guide wire and catheter itself. What I have seen when we do longer segments with a 360 Express is sometimes that coagulum and burnt tissue gets kind of sticky. So what ends up happening is the catheter can sometimes get uncoiled, so it'll start to look like that. If you see the physician or one of you are starting to take this catheter out and we're feeling kind of any resistance whatsoever, please disconnect the catheter from the cord and turn it clockwise. You see, as I'm turning clockwise, that electrode will start to fold back on itself and it will make it easier to pull out. If we're pulling out and we're finding resistance, doesn't happen all the time, but sometimes that just gets extra sticky down there and it'll start to uncoil. If we're finding that resistance, please disconnect the catheter from the system, roll it back on itself. You'll see that it'll start to fold back on itself, or we'll know that it's folding back on itself because we're not going to see it because it's in the patient, and we'll start to retract the catheter. Once we've retracted the catheter, we will hand the cleaning cap to the physician. Again, the cleaning cap is just like a little shovel that goes at the end of the scope. They'll go down, they'll clean that entire area. So we'll wipe all of that tissue off, all that white coagulum. They'll typically just push it into the stomach. Once we've completely cleaned that entire area, we will go down and we will burn that same area again. After the second ablation with the 360 and all of our catheters, after the second ablation, we're done. We do not go down and clean that area again. So once we're done with the 360, we've done our second pass is what we call it. We will pull the whole handle out and we are done with the procedure. We will disconnect the catheter, we will dispose of it because it worked as it should, and we're all done. We'll wrap up. So that's the 360 Express. So it is more involved. We do need a guide wire. We need the additional cleaning cap for the 360 Express. But overall, pretty easy procedure, and a lot of it ends up being on the physician besides some of the pre-work and stuff that connecting. They're going to do the auto inflation. They're going to do the ablation. They're going to place the catheter at the correct measurement. So a lot of that piece of it's going to be on that. So any questions when it comes to the 360 Express? Feel good? Okay. We'll transition then to the focals. The focals, we have a couple different options. I think you guys have all of them. We have the Ultra, 90. Do you guys use the 60, Mitch? The TTS. Okay. Do you guys use it through the scope at all? You guys do? Okay. Right there. Okay, perfect. So we have a few different options for the focal catheter options. We have a ultra long, which is what we used before we developed the 360. So this is what they would use to burn a very large area, and they would then burn circumferentially with the ultra long. 90 ultra long is what it's called. We have a 90 catheter, which is the same but just a smaller length of catheter. It's the same width as the ultra long, so 90 ultra long, 90. I won't talk about that. We have the TTS, so through the scope. This is the same size. We have a more rigid 60 catheter as well, but the through the scope is the same thing. It's just a flexible version of our 60, which is typically why this went away, because they just used the through the scope. So those are our options. These will again be determined once the physician goes down and does their index GD. Do we have little islands? Typically on these follow-up and subsequent procedures, do they have a very large tongue? You'll see these very large tongues. Is that like 2 to 3 centimeters? Or is it just these little islands that we just need to go down and retreat? So that will determine on which catheter they like to use. It's also up to physician preference as well. They might always use the 90 and never use the through the scope. They might only use the through the scope on some of these subsequent procedures, but just again, up to them. Just so you guys know, typically the TTS is for very, very small islands. We're typically not going to ablate very large areas or long tongues, with the TTS. It's a smaller catheter, it's less rigid, so it takes a lot longer to do a larger area with a smaller catheter. Seems pretty intuitive, but sometimes physicians will change that up on you at any time. So we'll start with the second most involved catheter, which is the through the scope. Everything from a pre-work perspective is exactly the same. Oops, sorry about that. So again, if we forget everything that I'm talking about today, please use the correct catheter sheet with the pre-work as we're walking through these procedures. It will walk you through everything that we need to do. One thing that I forgot to touch on in the previous, the physician will give you a couple measurements. So they're going to give you a measurement with both the 360 and the focals. They'll give you a measurement of top of the gastric fold. What you're going to do is you're going to circle, so say that the top of the gastric fold is at 40 centimeters. Please circle 40 and put top of the gastric fold, or you'll put TGF. And then they'll give you a second measurement, which is the top of the intestinal metaplasia, TIM. So we'll say that for easy math perspective, it's at 30, so it's a very long, or we'll do less than that. We'll do 35, so it's a 5 centimeter segment because the top of the gastric fold is at 40. The very top of the intestinal metaplasia is at 35, so we have a 5 centimeter segment of Barrett's esophagus. That's how we were doing our classification. So I apologize, but they will give you those measurements before we go down and place the catheters or do any sort of burning with the catheters. So again, they'll call out the first number, top of the gastric fold. Please circle that. Please put TGF. And then they'll say top of the intestinal metaplasia. Please circle that number and put TIM right next to it in this little area here. Once they've gone down and they've decided which catheter they want to use, we'll assume that they want to use, we just have a couple little islands that are throughout the esophagus that we're going to go down and treat with the through the scope. The through the scope is the second most involved catheter that we use. The reason being is we have a black little funnel, or what we call introducer. We need to put that in the top of the working channel so we can introduce the catheter to the scope. We will do everything the same that we talked about previously. We will dilute the mucomist. We will place the mucomist down. That will clean the area that we're trying to ablate. And then we will move forward with placing the catheter. So again, there's that little black funnel or introducer that goes at the top of the working channel. This is probably the most important thing today, guys. This needs to be folded. The catheter needs to be folded gold side out. Gold side out. Flour tortillas, not blue corn tortillas. Flour tortillas. I learned all this when I was an associate down in Houston, Texas, so that's the way that they taught me. The only way that I can remember it now, unfortunately. But it has to be with the gold side, to the electrode side out. I'll pass this around, but this blue side, it's a more plastic material. It will get stuck in your scope. I promise you it will. It is a pain to get down. It's also a pain to get back out because it won't come out the other side. I can almost guarantee it. So if it's folded with the nasty blue corn tortillas that we talked about, they'll place it and it will have, excessive force. They will try to force this thing down. It will not get to the other side, and then we have to take it out. So then the excessive force again, trying to get it back out. So if we can all be cognizant, typically what I like to recommend from a staffing perspective is kind of pre-fold it and like almost introduce it into the introducer your guys' self. So you're not necessarily handing it to the physician so they can introduce it and they, I don't want to say make the mistake, but they fold it the wrong way. So you kind of introduce it yourself, again, folded with the gold side out. Once the introducer is down and we've done it correctly with the gold side out, we will then progress to make sure that it will fan out on the other side of the scope. We don't typically run into any issues if we fold it correctly, but if there's for some reason, sometimes in that working channel we use it for a bunch of different things. There's some remnant fluids, if it didn't get cleaned properly, whatever the case is. If there's something stuck in that scope, you guys can imagine that this won't, it'll push it out in the other end or it might get stuck. So just be cognizant of that. But if you're seeing the physician have excessive force trying to get this down, it's likely that this was folded incorrectly. And again, I'll kind of pass this around so you guys can feel that blue side. It is, again, a kind of a sticky, rubbery plastic material that it will get stuck in the scope. Once we've placed the catheter all the way back down, that catheter will fan back out. We haven't connected the catheter yet because we listened to David on the previous section here that we don't want to connect the catheter until we're fully down in there. We don't want to ablate the inside of the scope. We just don't want to ablate anything that we're not supposed to be ablating. So once we've gotten the catheter all the way down, we will connect. Again, there's a white little dot here. There's a white little arrow on the catheter. Please line the dot up with the arrow. It just clicks on. These are just little collars. They click on, and then our preset settings will come and be pre-populated here. We don't need to connect anything with the air valve. That's just for the 360 Express. The foot pedal will be down by the physician's foot, and they will go and they will start to ablate these areas. For our focal catheters, we have some different protocols. So with through the scope and the 90 catheter, you're gonna ablate that same area twice. Then they're gonna clean it, and they're gonna ablate that same area twice again, and then they're gonna pull out. So depending on how many areas that they need to treat, that will change the number of total ablations. But say for whatever reason we have one island, we will go down, we will treat that spot twice. They will typically use the focal catheters to kind of scrape off that coagulum, so they're not taking the catheter all the way out, exchanging with the cleaning cap, going back down, using the cleaning cap, coming back out. That's typically only for the 360 Express. They are rigid enough. The TTS is less rigid, but the focal catheters are rigid enough where they can kind of use it to scrape it like a shovel. So we have one island. We'll go down. We will ablate that one area, 1, 2, scrape off that area, 1, 2, and then we will pull out, and we're done with that procedure. Again, depending on the segment and depending on how many islands or tongues we have, that will typically determine how many ablations. One thing that we need to be cognizant of as staff, this is not so the case on the 360 Express, but on the focals, it will tell you the percent of energy delivered. Let's be, as we're ablating and we're ablating these specific areas, if you guys start to see, and typically this happens on the second pass, if you start to see that number dwindle, if it's really anything but 100%, let's let the physician know. What ends up happening again is that white coagulum, that tissue, that burnt tissue, sticks to the electrode part of the catheter. What ends up happening is the more and more that is sticking to the catheter, the less and less efficacy that we have of the catheter, because there's, again, something in between it. So we want to make sure we're cognizant after every single ablation. It will tell you the percent of energy delivered. It will also start to count, with the focal catheters, it will start to count how many ablations we have. On the sheet, you will see how many ablations that we have. So we have first pass, second pass. A pass is defined as the first 2 ablations. Anything before we go to clean is technically a first pass. Some physicians don't ablate the whole area, then clean the whole area, then go ablate the whole area again. Some physicians, they'll just ablate, clean, ablate, clean, ablate, clean. So it's really hard to determine what's the first pass and what's the second pass. If you have a physician that is doing that they're ablating that one area, cleaning it right away, progressing to that next area that they're ablating twice, and they're cleaning after every second ablation, what we want to do at the end of the procedure, take the total number and divide it by 2. That's the best way that we can be cognizant of that. If you have a physician that does it per our IFU, which is ablate that whole area, clean the whole area, then go, which would be defined as the first pass, cleaning, then now we're progressing to the second pass, and they do that ablation. That's a little bit easier to know when we're doing that, but again, they'll typically just ablate, clean, so that makes it really hard to know what's the first pass, second pass. So if that is the case, and you have a physician that's ablating and cleaning after every single area that we're treating on these follow-up procedures, at the end of the procedure, there's going to be a total number. Please write that total number and then divide it by 2. That'll be the easiest way to show what our first pass was and our second pass. Typically, that number is an even number. If it's not for whatever reason, subtract 1 divided by 2 and then add another on the first pass to the second pass. If we disconnect the catheter before we look at this screen and see the total number of ablations, that number is gone forever. So before we disconnect the focal catheter from the cord, we want to make sure that we write the total ablations down. Again, if we disconnect that catheter at the end of the procedure and we forgot to do that, that number is gone. If we reconnect that catheter, that total number doesn't exist. Yeah.
Also, we need to make sure that we document in Epic in the procedure notes how many ablations we do.
Yeah. So again, another reason to be super cognizant to not disconnect the catheter before we take our notation of how many ablations there are. So that is through the scope. Place the introducer, which is that black. You kind of see it there. That black little funnel. Green or blue corn tortillas are gross, so don't use it. Flour tortillas, gold side out. Basically introduce it to the introducer for the physician so we know that it's going down the correct way. Introduce it fully and it will fan out in the other end, and then it's up to the physician to ablate their designated areas. So a little more involved, or the second most involved catheter that we have. To kind of finish up, which is the easiest in my opinion, catheter, which is the 90 catheter. The 90, what we're going to do is we'll go down, we'll do our index EGD, we will make our dilution of mucomist, we have a couple follow-up little islands that we're treating, we will get our couple measurements, so we'll get the top of the gastric fold, which again we're going to assume is 40, we'll circle 40, put TGF on the 40, at 35 is the top of the intestinal metaplasia. Crazy that they have the same segment as the previous patient. TIMs, or top of the intestinal metaplasia, please circle that and please put that TIM here. We will then we'll say, hey, we want to use the physician will recommend we want to use the 90 for this procedure. We will grab the 90 catheter, we will take it out. They will pull the scope out, and what this does is, you guys can see it has a little rubber cylinder that basically slides on the end of the scope. What we want to do is we want to look at the scope screen. It might be off to the side on our vision, but on the scope screen it has to look like a baseball cap. So please orient the catheter so on the actual screen, on the scope screen, it looks like a baseball cap. One issue that we run into is this part, the rubber gasket doesn't slide all the way onto the scope, so in the vision of the scope screen, you can see part of this rubber part. We want to make sure that it's flush. This part is flush to the end of the scope. We do not want to see any rubber part of the catheter on the scope screen. And again, we want to orient, we want to move it to where it is at the 12 o'clock baseball cap in the scope screen in for the physician. What that allows the physician to do is to make sure that it's the easiest way to orient and get in there and manipulate the catheter. So if it's at the 3 o'clock, it's just a little bit more difficult for them to orient it and get the areas that they want. So it just gives them a little bit more leverage when it's at the 12 o'clock. They will go down, you will plug in the catheter. Here, again, all of our focal catheters do not require this. This is just for the 360. All of our catheters have a little arrow on it. Please line the arrow up with the circle. It will click on. Again, they just click on here. All of our preset settings will come up. It'll say catheter is ready. Foot pedal will be down by the physician's foot, and they will go and start to treat those areas. Again, these focal catheters are rigid enough where they're not going to pull out and use a cleaning cap. They're just going to use the catheter to clean. Couple, again, takeaways. We want to be cognizant after each ablation that if it's saying anything but 100%, let's please let the physicians know, hey, we only got 80% energy delivered there. That could have been user error from the physician standpoint. Maybe it wasn't flush up against the skin. or likely there's some coagulum or tissue that's attached to the catheter here. It will start to count up how many ablations we've done. If they ablate circumferentially, then go and clean, and then ablate circumferentially, that will of course be defined a first pass and a second pass. First pass is the first ablation, anything before they clean, but if they're not doing that, please take the total number of ablations at the end of the case, write that in the total section, and divide it by 2. If we remove it, again, if we will remove the catheter from the cable before we notate how many ablations, it's gone forever. And again, being that you guys document that in Epic, that's a really important piece that make sure that we have. So that's it. That's the focals and 360s. Mitch, anything that comes to mind for that?
No, it's great, man.
Okay. Any questions? Yes.
Yeah, I've seen them use through the
Through the scope?
scope
Yep.
catheter in the stomach.
Okay.
Or, but then they don't use mucus in the stomach. They don't need it for that.
No, so that's likely another indication of ours that they're using for maybe a bleed.
Yeah, usually some oozing from gastropathy or
Yeah.
gave or something.
Yeah, so we have radiation proctitis, and we are indicated for radiation proctitis and GAVE. So for those particular, they have a different protocol. So if we are running into that, let me know or let Mitch know, and we can update some of the protocols for that. It's very rarely used like that, or do you see that it's they use it quite a bit?
We're a pretty big liver facility, so we see
Nice.
a lot of the abnormal stuff.
Okay,
Yeah.
that's huge. So then there's a different protocol with that. I can pull that up as well. I will also include, this is a newer troubleshooting guide as well. So if we're running into anything, please try to reference this. I will tell you all, full disclosure, turning it off and turning it back on fix about 95% of the issues. So just like your computer, just like your cell phone, just turn it off, leave it off for a little second, 30 seconds or so, turn it back on. It typically fixes any sort of system errors or anything like that. But I will include this troubleshooting guide. Again, as you guys can see, there's only really 8 steps from a troubleshooting perspective. Let's see if I can pull up. Nope. Okay, so here are our another kind of a quick reference guide, but it'll talk about the different catheters. It'll talk about the ablation and cleaning protocols. So it will list all of your ones, like we talked about. 360 is going to be that one ablation, clean, and one ablation for that particular part of that segment. If you have a very large segment, it's going to be one burn for the top part of that longer segment, one burn for the bottom part of that segment, clean, and then we'll ablate the top part of the segment and we'll ablate the bottom part of the segment and pull out. So sometimes this gets a little confusing because we do ablate more with longer segments with the 360 Express. So don't get super caught up if there's more than one ablation. It's one ablation for that segment, clean that segment, one ablation for that segment. Again, we might have longer segments. So we'll talk about here. So for GAVE and radiation proctitis, that's really exciting that you guys are actually using it for that. Not a lot of people actually know that we have that indication for RFA. So it talks about, again, for GAVE, it'll talk about all of the different catheters. We do not use the 360 Express in the stomach. There's really no point in doing that as it's a circumferential burn. We do not want a circumferential burn in the stomach. It really is not that effective. So you'll burn 1 to 4 times, and there's no cleaning. We're not going and we don't want to scrape that area that's typically oozing or bleeding or anything like that, right? So, and then radiation proctitis, 1 to 2 burns for the different catheters as well. So, and then no mucus. Thank you for making that point as well. So, you have all of these. I will make sure to, again, resend these to, I think they're all in here. I looked. So they look like they're all in here, but I'll make sure to send all these as well. So if we need them, we'll have digital copies of them so we can print them off before the case if we don't have any copies in the actual drawer itself. So, And then if you need me, just let me know. That's what I'm here for. Again, I'm local. I work with Judy a lot. I work with Mitch a lot, but hopefully get to work with you guys a little more. And if you guys need anything, just let me know.
Thanks, David.
Yeah.
Appreciate it.